Welcome to the Protecting Your Nest podcast. I am so excited to be recording this episode because I am recording it on the third day of the Low Carb USA San Diego Conference. And as you can see, I have a wonderful guest with me, Dr. Robert Cyrus. I had the privilege of speaking on the first day of the conference, and I talked about the mitochondria and how understanding the mitochondria is very helpful to understanding how to determine the root cause of disease. My partner here also spoke, and he talked a little bit about, his thoughts on weight loss and how our mind and how we think affects it. And I was really privileged to be on that stage. We had Dr. Dave Feldman, we had Chris Palmer, Dr. Eric Westman, of course, Gary Tabbs and Dr. Brett Scher, Dr. Joan Iflin, among others. So it was really a great opportunity to stand on the same stage as the low-carb experts in the country stand on. So I really want to thank Pam and Doug, who lead the Low Carb USA team, for the work they're doing as we are spreading the message of metabolic healing. But my guest today, Dr. Robert Cyrus, is a weight management doc and a bariatric surgeon, and he really treats both adults and children in the Florida area. His medical training began in Cape Town, South Africa, where he received his medical degree from the University of Cape Town in 1989, and he moved to North America and completed a year-long residency in pediatric surgery at Ohio State University's Columbus Children's Hospital. Then he came to Canada, where he completed his general surgery residency, and he specialized in minimally invasive surgery at the University of Toronto. And he then earned a Ph.D. I guess he was bored and wanted to get more education in liver carbohydrate metabolism, which is really important because we're all interested in carbohydrates and how it affects our body. His research led to a comprehensive understanding of the toxicity of chronic excessive carbohydrate consumption as the primary source of obesity and the so-called obesity-related comorbidities. And that's why I really wanted to bring him to this discussion so we can talk a little bit about that and how he approaches his patients. And so he's become this well-known, internationally known doc, and he has a center of excellence for obesity surgery. And the practice he uses cognitive behavioral therapy as he addresses carbohydrate addiction and uses bariatric surgery as well in the appropriate clients. So with that, Doc, welcome to the Protecting Your Nest podcast.
Thanks so much, Tony. Thank you very much. And thank you so much for your representation in this world as well. It really is a footprint that had not been put on the ground yet. And you really have pioneered that, almost like Neil Armstrong's first footprint on the moon. It's a big deal. And as we expand this, that print will always be there. So thank you for what you do. I really appreciate it.
Yeah, I appreciate that. And it is, again, I've been welcomed to the low carb community, and for the first time had a chance to meet my colleagues face to face. So it's been a wonderful experience. And I think we all on the same mission, which is we got to save as many lives. We can't wait for guidelines to change, and we need to do it as soon as possible. So let's kind of start our conversation by talking a little bit about why you even got into the medical profession. I know that's been a little bit ago, but talk a little bit about what was your driving force back then.
Well, getting into healthcare was easy. My dad was a doctor, and it was the default option. And really, it's amazing how over your career, and I'm kind of in the back third of my career right now, how things evolve. And if there's a message for young doctors out there, you may have an ideologic person, physician that you want to be, but allow your passions to dictate what direction you go. I'm a bread and butter pediatric surgeon who wanted to get into liver transplantation. And as I did my Ph.D. in liver transplantation, I realized there was this enormous misunderstanding of what sugar was doing, because we blamed what sugar did on fat. And I clashed with so many people. In fact, the hypotheses that we had in the lab were fat causes all this damage and the liver needs sugar. And
that's right.
When we found that was exactly the opposite, it took me down that pathway. And I was fortunate in that I allowed myself to be drawn along my passion pathway rather than what was best for me as an academic doctor.
Okay.
So I forsook one pathway for another. And sometimes following that, could I have been wealthier? Could I have been more famous in the academic world? Absolutely.
Mm-hmm.
But I did not want to stay in that, what I considered to be stuck in those molasses.
Right.
And this was
That's right.
a new arena. Plus, also there was a personal aspect to this because at the time I was a victim of emotional mismanagement. We'll get into that in a little bit
Mm-hmm.
myself. And I was trying to improve myself in terms of how I manage stress, anxiety, even boredom and pleasure. So there's a
Wow.
duality. And, as we've evolved into this, Tony, it's interesting, and you'll experience this as well. I think you are. We physicians face two ways. We face inward toward our colleagues in the healthcare system,
Mm-hmm.
and then we face outwardly toward our patients. And what's unique about this space is that, and you mentioned this, and it kind of put a little red flag in my head a second ago, is that you said we want to help people or we want to change. We can't. We can, this is, if I operate on somebody, all they have to do is show up. With what we do in the office,
Mm-hmm.
you are not helping anybody. You're helping them to help themselves.
Mm.
And there's a whole different dynamic because it's how we connect with people, how we help them to understand and benefit from our connection with them to help themselves. And there are a lot of doctors out there that don't
Mm.
have that skill set.
Mm-hmm.
And they're probably best in the operating room taking our gallbladders. So we have to dissect those metrics and understand you can give somebody diabetic medication all day long
Mm-hmm.
and educate them. But if you don't help them to understand they need to stick a needle in their finger, they need to
That's
take
right.
their medication regularly, and less than 25% of diabetics do that, you're not helping them with their disease. Even though you've got the best medication, the best algorithm,
Yeah,
if you're not able to translate that into efficacy, into actually putting on your Nikes and doing it and helping them to do it, it doesn't
it's
help.
not going to work.
Mhm.
And it's pretty amazing when I think about how a clinician defines success. And a lot of it is I diagnosed the right medical condition. I was able to kind of fix your problem, but they don't realize so many other aspects of being a good clinician. And some of it is what you're saying. You have to kind of understand, why people struggle and how can I help them as a clinician not struggle. But we're not taught that. We're just taught diagnose the condition, treat it, or have surgery or do a procedure, and you're a great doctor. And I think that paradigm shift is going to require the entire system to change. And so as we get our new clinicians on board and joining us, we have to make sure they understand. They have to just know what you just said. If they don't, and they want to be good clinicians. So once they know this, they will probably engage, but they don't know it and nobody's telling them. So that's why I love being at Low Carb USA and being able to share messages that are not traditionally shared. So I think that's awesome. So you're a bariatric surgeon and you're talking about, how people think, and we're going to talk about emotions, but you're a bariatric surgeon. That doesn't. So how did you as a
Right.
bariatric surgeon start to see the forest for the trees when it comes to that way of thinking?
Well, bariatric surgery is extremely good. It is the best diet you can be on, extremely good for weight loss. And no matter what anybody's viewpoint on this is, there are a subset of people who have struggled. They're experts at failing weight loss programs. And I look
Mm-hmm.
at bariatric surgery not as an alternative, but as an adjunct to a pathway. It's a
Okay.
tool that you use. It's like tried to quit. I don't smoke, but I've tried to quit smoking many, many times, doc. Would you write up some Chantix? No doctor would deny that patient Chantix if
Okay.
they've tried many times.
Sure.
Why not think of bariatric surgery under similar conditions? Is that
Mm-hmm.
I've tried. Don't jump to that first as a magic bullet, as an easy way
Right.
out, because it's not. But it is something. Ultimately, it's the success of our patients we're looking for, and I believe we should launch every tool possible at them to help them.
All
So
right.
bariatric surgery is something that helps people along a pathway rather than becomes an endpoint.
All right, cool. So that makes sense. And then I had the pleasure of hearing your presentation today, and I really enjoyed it. And you said, do keto, veterans develop protein lipid resistance, and you talked about how, how we actually gain weight, which is an important question to answer. And you talked a little bit about why calories and what, you made a statement that was kind of interesting. You said that, purpose-driven hormonal imbalances define calorie impact. So for those who are watching and listening, let's talk a little bit about what you meant
Sure,
by
I think
that.
that this is such an important concept because there are misunderstandings, or it's oversimplified. It is absolutely true that in order to gain weight, you have to eat calories. Okay, and those calories can be protein, carbohydrates, or fat.
Okay.
And when I talk about purpose driven, the calories are driven by the purpose for which you eat them. My 1-year-old baby is growing like crazy.
Yeah,
So the purpose of him overeating is for growth.
that's right.
A guy like Zach Bitter, who's the world 100 mile record holder, and he does over 100 miles. He's averaging 6.5 minutes per mile over 100 miles. I mean, that
Okay.
is, I can't do 6.5
Yeah,
on
I
1
mean,
mile.
right.
So if you think about the energy, the caloric volume that he has to consume to complete a 100-mile race,
Mhm.
and he's lean, he's a skinny guy. Google him. The driving force behind his caloric consumption is endurance support.
Okay.
A guy who's a muscle builder, the purpose there is to eat protein to build those muscles to augment his size as he works out in the gym.
Okay.
And then you've got an obese person, and this is what most people don't understand. The obese person is overeating sugar and starch, primarily calories, for its emotional value. Just like the alcoholic drinks excessive amounts of alcohol for its emotional value, for its pleasure value. So that is the purpose of drinking alcohol, of using carbohydrates. The
Gotcha.
purpose in obesity is for pleasure. And that pleasuring yourself with carbohydrates, managing emotional tension with the instant gratification that you get from sugar and starch in a snack, the result of the consequence of that depends on your biology. So obesity doesn't cause disease. Obesity is the consequence of dysfunctional emotional management. But it could have been diabetes. It could have been metabolic health. The outcomes are not the problem. When someone gets a DUI or liver disease, the problem is not the liver disease. The problem is the alcohol they're consuming, and the
Okay.
liver disease is the endpoint. You can manage the liver disease, but if you don't manage the alcoholism, that's
Yeah.
silly. So to manage obesity with a diet, with a calorie reductive diet, which is ultimately, even a keto diet, is still caloric reduction. It's just not intentional. It's vicarious because you're not hungry. So you don't eat
That's
as much.
right.
However, if you don't help that person to also simultaneously change the reason they overate those calories, which is that change their foundation of pleasure, where they derive emotional dissipation from, they're going to go back to that old methodology under emotional distress.
Is this now, if I think about myself, and I think in a previous podcast, I talked about how my mom, um, was right before we can actually get close to each other because we're both vaccinated
Mhm.
and we're safe.
Yes.
But she was upset because, we weren't going to gather. So I just said, I'll eat everything that you prepared. And so she prepared two sweet potato pies and handed it to us, and amongst other starches,
Mm.
which I normally don't eat. And so part of it is that I was able to, not eat it when I didn't need to eat it. But then when I was at work, I was thinking about the sweet potato pie. So I guess my question is, I feel like I have a lot of, self, ability to resist these things. But if I get the average person in front of me, what's the chances that we have to get really deep and think about their emotions as opposed to just the average person? And do you find that a large percentage of people you have to dive deeper, or or is there a group of people you just say, hey, just get your carbs under 20, you'll do fine? Do you think all of us need that extra support?
I think, Tony, there's use, abuse, and addiction.
Mhm.
And look, I drink alcohol. I've been drunk in my time. I'm not an alcoholic. And the
Right.
difference is that I use alcohol from time to time for emotion management, but it's under very tight control.
Hmm.
So therefore, chronic bad things haven't happened.
Right.
Okay. However, and I've topped out at 300 pounds, my relationship with carbohydrates is such that I developed such a powerful, positive relationship with carbohydrates in terms of their enjoyment
Hmm.
that I was able over time to distort the reality of the harm by minimalization, trivialization,
Hmm.
rationalization to justify the ongoing value of eating carbohydrates for pleasure. And by the time you get to a point of tangible harm, obesity, diabetes, metabolic syndrome, and you are continuing the relationship,
Okay.
that relationship is and always will be broken. That defines addiction. So addiction is defined by harm, extensive harm. And once you reach that point, that relationship is broken. You, on the other hand, may abuse them from time to time,
Right.
and you may use them from time to time, and you have the capacity to control that relationship.
Okay.
I don't. So addiction is managed through permission because of that. As you said, it's that thought process, and
That's
the
right.
difference is you can rationalize and put boundaries around that thought process. I can't.
Okay.
And that's why abstinence is the order of the day. But abstinence is not enough. You then have to find a replacement for that emotional dissipation that you no longer have methodology about. So I think the big distinction is this. To summarize what I just said, carbohydrates are not the problem. It is each individual's relationship with it that is.
That's right.
And my relationship is broken. Okay. My relationship with alcohol is good. My relationship with carbohydrates is broken. Yours with carbohydrates is still good.
Right. Right.
So don't demonize someone who eats carbohydrates.
Right.
Unless, I mean, they may be obese, but then they've chosen that or they've decided that. And here's the way that I look at it. And this is a simple way to determine, not just based on the outcome. If you have remorse for what you've done, that's problematic. You know, we were talking earlier on, before this, about your leadership work in the hospital and that kind of thing.
That's right.
If you have a negative interaction with a patient or a colleague, and you walk away from that and you feel remorse, that's on you. If you eat both those sweet potato pies,
that's right,
and then you're overstuffed and you're uncomfortably full and you have remorse, that's problematic.
That's right.
Does that make sense?
That makes a lot of sense.
And so what we try to do here is get away from doing things that have remorse. If I go for a walk, I may come back and I may be sore and stiff afterwards, but there's no remorse. There's pride.
You feel good.
And if I feel pride about what I did without remorse, that then we can embrace that and enhance that.
I love it. And what I also love is, first of all, I love my mom's sweet potato pie. let's say that first. And I didn't have remorse, so I may even, it's going to trigger me to maybe ask her to do it again, because that is how we show love towards each other. And I think periodically, and anybody listening to this podcast, understand that we are about analyzing and looking at yourself as individuals, and you do what's best for you. And for most of us, we can have moments like that. And so I just wanted to say that first. But I'm also curious, when you think about we come to your team and we want to get care, I want to get a feel for what that looks like. So when somebody meets you for the first time, how do you what's that process? How do you assess them and determine what their needs are? Just give me kind of an overview, and also how your team kind of supports you in the work you do.
Sure. And I think, what's important, I believe, in a practitioner, it doesn't have to be a doctor, but a practitioner that's there to help folks with their diseases and with the illnesses that have come from this relationship, we have to have a duality. The first part is we have to understand the science and the biology and the pathophysiology of that harm so that we can monitor and correct the disease process at an organic level.
Okay.
So we've got to do blood work, we've got to do certain scans, and we may even need medication to treat some of those diseases permanently or transiently.
Okay.
The other part is we've kind of have to have the dietary psychologist role, because you can have all the science in the world and all the knowledge in the world, and we've advanced our knowledge in this science tremendously. But really what you want is to develop the methodology, not only to help the patient develop ownership of their issue, because the last person to ever know they're an alcoholic is the alcoholic themselves.
That's right.
And so, because we're so good at mitigating and distorting the reality of that relationship, so the first part is help me to objectively connect with the truth of my situation.
Okay.
And then, if by the time you get to a point where you have ownership of the problem, it's the size of an elephant. Oh my God, I didn't realize how ubiquitous this was.
That's right.
Because it's not only about carbohydrates, it's about snacking, it's about the thought process all the time. And because it's your emotion management system, it is omnipresent and omniprevalent. You dream about it, you think about it, it's there all the time.
That's right.
And to eat that elephant in one bite, you're going to choke. And too many dietitians say, here's your sheet of paper,
That's
no
right.
carbs,
That's
here you
right.
go. And you do great for a little while, but you crash and burn.
That's right.
So doing it is easy. Sustaining it is the challenge.
That's the challenge.
And so therefore, if you break that elephant up into little pieces and you eat it, and we give you, okay, do this bit of homework now, but I want it all. No, slow down. Be the tortoise, not the rabbit.
Okay.
This
Okay.
took a long time to evolve. It's going to take the rest of your life in forward progress to make this
That's
move.
right.
But as long as you're moving forward, you're getting better.
That's awesome. And you kind of another trigger word you mentioned was snack, right? So I am curious. You know, I find that I don't need snacks because I think when you do intermittent fasting and keto, it's the lunch hour. We may have lunch because we have a break during our conference, but I can go all the way until I think yesterday I didn't have anything to eat until the first day I arrived. So on the day I had to speak, I didn't eat anything until 5, and I was still fine. Now, but I find that I don't need snacks. But the question is, are snacks okay? Like if I'm a person who's following a healthy dietary plan, some people would argue, well, you don't really need snacks because you should eat enough when you're hungry and you shouldn't have to snack, right? And then there's other arguments. Well, if it's a low carb or keto friendly snack, who cares, right? So how do you deal with the snacking question with your patients who have the habit? I have plenty of people I love dearly in my family who hide snacks and they love snacking. So how do you deal with that?
Well, let's define the purpose of what a snack is.
Okay.
Okay. And I think I'll take you task on a little bit on this, because if once we define the purpose, you actually do snack. But I'm going to fill it in for you.
Okay,
But you see, you're looking at the pragmatic aspect.
Okay.
I'm looking at the purpose.
Okay.
The human brain can focus for around 15 to 20 minutes at any one time.
Okay.
And what happens when you focus, dopamine builds up in your brain cells, and it reaches a critical point where you need this flooded relief.
Mm-hmm.
It's almost like a windshield washer driving in the rain. The rain's falling on your windshield. You hit the washer for a second, it cleans the windshield,
Okay.
and then the rain accumulates. That's
right.
how our brains work. So this emotional tension, this focus builds up, and every human being needs what we call a mind cleansing moment about every 20 to 30 minutes.
Okay.
And the brain will take that break whether you're in the driver's seat or the passenger seat of that break. And every human being can be defined by the dominant thing that they do to give themselves that break.
Okay.
Okay. Now, that break has to be an endorphin activator.
Okay.
It could be a cigarette. It could be a calorie-containing snack, often a carbohydrate. It could be a moment of prayer. It could be stretching.
Nice.
It could be looking at your Facebook account. In other words, everybody has a dominant thing and often a small range of things. But in the substance world, the substance is so powerful at that instant gratification.
Okay.
We develop that relationship. The smoker's always got their cigarettes and they're always thinking of that moment.
That's right.
So when I said you did snack, it may not have been a calorie-consuming thing you put in your mouth, but if you're human, you did something to give yourself that mind-cleansing moment.
That's
and a large part of obesity management is helping people to redirect that. So many years ago, I coined the term bridge.
Mm-hmm.
So instead of having a cigarette when you quit, you have a piece of gum.
Mm-hmm.
And instead of having a calorie-containing snack, for me, a bridge is something to get across that mind-cleansing moment that doesn't do me caloric harm.
Okay.
Because you might say, oh, it's pepperoni, or it's cheese, or it's a keto snack.
Mm-hmm.
But the point is that purpose has no nutritional purpose. It's an emotion management purpose. It's a mind cleansing moment purpose. So therefore, that's calories for your head, not your body. So what do? I use coffee. I went from drinking a case of Coke a day to drinking coffee. Is coffee perfect? No.
Right.
But it's become absolutely perfect for me as that mind cleansing moment. So whatever you do, don't get between me and my coffee.
I love it.
Does that make sense?
It makes sense.
And whether that's water or whether that's a Diet Coke,
Mm-hmm.
it doesn't have to be perfect, but it should be better than what you're doing already.
I love it. First
Does
of all,
that make sense?
I love it. And shout out to the coffee because when we finish, even though it's midday, I plan to have my first cup because I didn't have my cup earlier because I was getting to the conference. But I'm also thinking about my kids. I have 2 kids. They're at WashU in St. Louis. So I have a senior and I have a second year in a master's program. And they're doing this low carb, intermittent fasting lifestyle. And they're doing really well because of it. But hearing you talk about, hey, the brain can only focus for a certain amount of time, I think they need to hear that message. Me and the wife, we're going to start meditation. So maybe I can take a pause and do that. Take a brief walk, drink some water, coffee. But and it gives you an opportunity, first of all, to be more efficient at what you're doing. I'm in school still studying for nutrition. So I just think that just giving people those common sense approaches and tools. And I think, again, going back to the clinicians out there, you need to be given some tools. we learn things like motivational interviewing, for example. So if we have little nuggets of tools when we're faced with a patient, and if you're, maybe a dietitian, client, patient, you want to have these little nuggets. So I think that's really helpful. So thank you for that. I also want to just briefly talk a little bit about, why do we eat in excess? And it sounds like it may be related to, our, endorphins and things, but why do we eat in excess as a general thing? What do you think about
Well,
that?
I think, as we said, is there's a variety of different purposes,
Yeah.
and every purpose changes your hormonal milieu. So my son, my baby, when he's eating, he's activating human growth hormone and cortisol. When Zach
Okay.
Bitter's running, it's cortisol. So when the obese person and the type 2 diabetic's eating, consciously or subconsciously, they're doing this for instant gratification, instant emotional dissipation. So what you're activating is a genetically based chemical pathway in our brain called the endorphin center,
Okay.
that gives you instant relief.
Okay.
And the difference is, so the way I look at an emotion management system, which is governed by that endorphin system,
Mhm.
there are two ways you can activate the endorphin system. And a healthy person has both. The first one is the instant gratification.
Okay.
And it may be those little mind cleansing moments. It may be those M&Ms or that cigarette or that shot of whiskey or that hit of heroin.
Okay.
And those are dysfunctional substances that we use, or dysfunctional relationship with a substance we use for that instant relief.
Okay.
The other, and you know what's unique to carbohydrate addiction? If a cigarette does not contain nicotine, nobody's going to smoke it.
I can see
Okay.
that.
But there is a separate form of instant gratification called process addiction.
Mm-hmm.
And that may be gambling, sex, pornography, cutting, but it's also yelling and shouting and screaming, disruptive behavior, spousal abuse, anxiety. There are so many.
That's a form of addiction.
Of course they are, because when you're all stressed out and you yell and scream at somebody, you get that instant relief. When you're driving down the road, Tony, and I know you're not this guy, and I've modified this. I'll give you an example. And some idiot cuts you off on the road. You get that fight, but then you get angry at them, you yell and shout at them, you maybe show them the driving finger. You are dissipating that emotional tension, but you're taking his angst or her angst and making it yours, that you then have to go and eat some ice cream to dissipate later.
Okay.
Instead, if you can say, look, this guy just cut me off. He didn't do that to me.
Mm-hmm.
Okay. He's having a bad day. I'm not going to let his bad day be my bad day. And you pull back and you let him go.
That's right.
That is a better way of emotional dissipation. Does that make sense? So there's ways to alter both the process and substance, instant gratification. And we're all victims of that.
But I never thought about, because I manage, I talk to patients often about, how to deal with a moment like somebody's, cutting in front of you or something. And I never thought about it as emotional dissipation. I just thought, there's a better way to handle this situation. But it's just a different way of looking at it from what you're saying. And I agree that, your stress level is so much better managed by not allowing those moments. Like you said, it's their problem, not yours. And what I tell patients, let's think about what this could be about. Maybe somebody in the car is in labor. Maybe, there's an emergency and that has nothing to do with you. And because they're trying to make things happen, they may be a little intense, but don't internalize that for yourself. But emotional dissipation was never on my radar. So that's a nice nugget.
And that's the whole concept of, most often when we don't think this through,
Mm-hmm.
we step into the emotion with a knee-jerk, predetermined pattern.
That's right.
It may be yelling and shouting. It may be eating something. It may be crying. What I also try to help my patients to do is to step back.
Mm-hmm.
And if you can say, okay, this thing triggered me. I got this horrible text. That guy cut me off. And you learn to step back from that, mm-hmm. and do something that dissipates your instant emotional tension. Have that sip of coffee.
That's right.
Have that little moment of prayer, whatever it may be. Okay. Learn to smile and just be quiet. So what you do is you allow your own emotion to dissipate. Then you can look at the issue.
That's right.
Okay, this guy cut me off. Does it matter? No, let him go.
That's right.
Or you know what? He cut me off and he bumped me. I've got to take care of that. How do I? Right. So you can be pragmatic about how to handle the issue rather than emotional about handling how it made you feel.
That's right.
And the
I love
more
it.
effectively, Warren Buffett said something beautiful about communicating with people.
Okay.
And there are people that upset us and annoy us from time to time. And he said this: you can always tell someone to go to hell tomorrow.
Okay.
But what you're doing is you're buying time
That's
for
right.
you to evaluate the purpose of that rather than you knee-jerking.
I love it.
Does that make sense?
It makes a lot of sense. It reminds me of I was talking to one of my colleagues about, how do people remind themselves of this way of thinking, and what this one particular person does on their laptop or wherever, on their phone, they put weight. And for them, what weight means is an acronym. Everybody know it. I love acronyms. Why am I talking? Right. So what they do is they pause, and even just the act of pausing would probably. I think about people like Obama, for example. He always pauses before he says anything, and sometimes just the act of pausing, just a little bit, will allow us a chance to kind of think through what I want to say, how I'm going to respond. But just listening to people and pausing, but just remember wait, and that's a nice tip to help us all do that. So those are good tips. I appreciate that. I also want to.
Let me just say, it doesn't mean that you're not thinking.
Right.
It's a little bit like if you get that really bad text that upsets you, you may write the next text, and it's the Brene Brown, who I absolutely love, calls it the SFD, if I may use a word. You call it the shitty first draft. It's your emotion, but you don't hit send.
Okay.
You leave it for a few seconds, or for a minute or two, or 10 days, or whatever it may be. You come back and you review it again from a pragmatic perspective. You remove the emotion out of it, and then send or not send the evidence. And the same thing that Obama does is what he's doing is he's not talking, but he's thinking, he's reviewing in his head.
Right, that's right.
Another one on the other side, George Bush, 9/11. Where was he?
Right,
he was sitting in a children's room doing the No Child Left Behind, reading stories.
That's right.
Oh, you know what, Mr. President? A couple of planes into the. What did he? Most guys would have jumped up and gone to do stuff. He continued to read.
That's right.
Clearly, his brain was racing.
You can see
but he used that mind cleansing moment to say, okay, what are the facts? What do I need to do?
That's right.
If he jumped up and done something bad, it might have ended up.
That's right.
So, if you look at leadership, it is often defined not about being great people, but being great in the moment. And there's a big difference. And the knee-jerk response causes chaos.
Yeah, it causes chaos.
Whereas being thoughtful and leadership is being thoughtful about the facts.
I like that. Okay. And then I know you have a team, and we talked a little bit about how important it is to have a team. And so your patients come to you. You've given us a sense of what happens when you interact with them. You try to figure out what their needs are, and then you kind of create a plan. But I know, like we just had a great lecture we listened to with Dr. Joan Iflin. She's also an expert on processed food addiction and does it slightly differently, but very, very focused on helping people in that space. So my question to you is, when you get people engaged, they're trying to follow this process of thinking about emotions, etc. How do you support them so they stay focused? Do you have behavioral health people that help out? Like, what's the whole team dynamic and support looking like?
So I think we've got to look at what the needs of the patient are. First and foremost, pretty much everybody that comes in has illness at some level. And that is where the doctor comes in to diagnose and treat or manage that illness. Okay, whatever it may be. And we do blood work. We have to also dig under the covers a little bit and evaluate them from a diagnostic perspective. Not necessarily therapeutic, but a diagnostic perspective. I want to know what the diseases are. So the first thing, there should be a medical interaction, and blood work and evaluations as needed are part of that. The second part is we have to have that conversation. I try to have that first conversation about ownership and addiction. That it's carbohydrates. Now, when you go down the pathway of removal, what do you replace it with? So we need a dietitian who is going to help the person to design what they should and should not be eating, and more importantly, how and when they should be eating. And a large part of our dietary focus is not just what you're eating, but predetermining when and what you're going to eat. You see, most of our patients have lost the capacity to make choices, but they've retained the ability to make decisions. A decision is, what am I going to eat tonight? A choice is, I'm standing in front of the fridge. What do I want to eat? And
Okay.
especially if
Okay.
there's your mother's pumpkin pie or
That's
sweet
right. Sweet
potato
potato
pie
pie. That's right.
versus the steak. But if you've already predetermined tonight, I'm eating the steak.
That's right.
Even if you encounter that pie, no, I'm eating the steak. So that the dietitian has to be much more than just nuts and bolts, macros and micros.
Yeah.
It's principles and pathways. And then the third piece is when you remove carbohydrates, if you look at an obese or a diabetic or a metabolic person's, if you open their emotion management toolkit, they've basically got carbohydrates and cobwebs.
Right.
So from a dietary perspective, if you remove the carbohydrates, now they've got nothing, no tools in their toolkit to help them to manage their emotional needs in what I call an effort-based way. So the psychologist or the therapist is there to help them to build up a robust, diverse, effort-based system.
Gotcha.
And the foundation of that effort-based system is 4 pillars.
Okay.
Physical activity, not exercise, but physical activity,
right,
as an
movement.
endorphin reliever.
That's right.
Creative arts. Any of the arts where you can get lost in them, whether it's doodling, painting, reading, writing, gardening, cooking, fashion, photography. Spirituality.
Okay.
And spirituality is not just church and Bible. It's more an ongoing dialogue with a higher power where you're asking for guidance with things that you're not ready to talk to other humans about.
Okay.
And the fourth one is empathetic human connection. Most people think they're really good at human connection, but empathetic human connection requires you taking the risk of being vulnerable.
Okay.
And so we need that therapist to help folks in that direction. Because when you remove carbohydrates, you leave 2 big holes in your life.
That's right.
One's a nutrition hole, and the other one is an emotion management hole. And the nutrition hole is easy. That's the weight loss, and everybody does that, and they lose weight for a little while.
That's right.
But if you don't fill the emotion management void, when life throws an emotional curveball at you, and it will be a good one or a bad one,
Always,
it will.
24/7.
If you don't have the tools to respond, you're going to go right back and destroy the best diet out there.
That's right.
Destroy all your success. People lost 80, 100 pounds on Atkins, and they gained it all back.
Yeah.
So that's the principle that we follow in our practice. And each one of those doesn't just need to be introduced, they then need to be monitored and managed.
What's interesting of understanding this idea that too many carbs can be harmful is pretty interesting, particularly when you think about my previous life as a vegetarian, right? So when I was a vegetarian, I only ate carbs, right? So I'm just curious, I think about and I've even in my current practice, I have vegetarians who are obese and they just figure if I just don't eat meat and animals, I'm okay. And we've learned, maybe the pasta still can be harmful. It's not really food anyway. So when you think about this idea that carbs can cause harm, and you think about vegetarians, that's a lot to reconcile. So I know that the Diet Doctor has a low carb version of the vegetarian and vegan lifestyle for those people who choose that. But how do you reconcile the fact that carbs can be the thing that's harmful, and yet you have groups of people who only eat carbs? What do you think?
Well, I think the key thing to understand is that person, that vegetarian who's obese, they're not really a vegetarian. They're a carboholic. And it just so happens they don't eat meat. I have no problem. Let me back up a little. The issue is carbohydrates. Okay, the issue is that's like saying, okay, you're an alcoholic, or you drink water, but you drink alcoholic, and I drink maybe Diet Coke with my. No, it's not about the Diet Coke or the water. It's about the alcohol. It's about the carbohydrates. It doesn't matter whether or not you eat meat or vegetables. So if you successfully remove the carbohydrates, I don't care if you're predominantly vegetarian or predominantly carnivore-based. That is a choice. The range of food that we can eat, and this is where sometimes the dietitians are complicit with the problem. Yes, meat products do not contain carbohydrates. That's easy. So eggs, cheese, red meat, white meat, dairy, poultry, fish and seafood don't contain carbohydrates. They're okay to eat because they're carbohydrate free. 100% of vegetables, by definition, are made of carbohydrates.
Right. That's it. Right.
So the principle that I always advocate for is it's not carbohydrates that are the problem, it's our relationship with it.
That's right.
So I've never met somebody, an obese person who had a really rough day, rushed to the fridge and picked out on Brussels sprouts. Right. So if you're going to be a vegetarian, eat vegetable products, but stay away from the grain products, stay away from the rices and the potatoes. Those are the three that we stay away from.
Mm-hmm.
And for the rest, vegetables are okay. Now, the further part of this is you do need to get in some fats,
Mm-hmm.
especially the saturated and the 3 and the 6 omegas, which are the essential fats.
Do you ask them to avoid vegetable oils as well? How big of a
To
deal
a
do you
large
make
extent,
that?
I do,
Okay.
yes. Because you can find avocado oil, olive oil, and coconut oil as surrogates or better substitutes
That's
for those
right.
others.
That's right.
Okay. Now, if
Okay.
you want to use some sesame oil from time to time,
Right.
it's not a crime.
Right. Right.
To my mind, because the sesame oil, I'm not going to eat in abundance if I don't eat it with carbohydrates.
Mm-hmm. Gotcha.
Nobody's going to pig out on seed oils.
That's right.
Without carbohydrates.
Right.
And that's the
That's a
interesting
good
thing.
point.
Yeah.
I hadn't thought about it. That's right.
So, you don't pour a gallon of Crisco on your lettuce.
Okay.
It doesn't work that way.
That's right.
Okay. So, but if you're baking cookies, the gallon is in the cookies.
It's in
so the seed oils are vicarious, not intentional. You want to educate people about them,
mm-hmm.
but you're not going to overdo the seed oils if you're eating vegetables.
That's
And
right.
then the other piece is finding adequate protein. So the ideal for me, if you want to be vegetarian, unless it's a religious foundation, find something like eggs or fish or dairy
Mm-hmm.
that you can incorporate from time to time, primarily for its micro and macronutrient value.
Gotcha.
And I find eggs are acceptable to most people.
Right.
And an egg is a whole animal. I mean, an egg is nature's Rubik's Cube. You take an egg, you do this, you have a chicken.
That's right.
So it's got all the micro and macronutrients in the right proportions.
Gotcha.
So, but again, that's a choice.
Okay.
And if you lean on the more carnivore side, it's fine.
Okay.
I don't mind. But those are choices, not necessities when it comes to diet.
All right.
Nobody tells an alcoholic what they should drink.
Right.
But we love to tell obese and diabetic people what they should eat.
Right.
And it's based on our biases.
Interesting.
It's more about don't eat this, and then whatever else is left is fine.
All right, cool. So I'm still thinking about the patient who's coming into your office. And, I'm a big fan of metabolic health. That's why, and thank you for your leadership. You're leading one of the committees with the society. I think is it the research committee?
Yeah, it's the research committee.
The research
Yeah.
committee. So with the Society of Metabolic Health Practitioners, I'm on the outreach committee for the Society of Metabolic Health Practitioners. So we're trying to spread the word. But one of the things that you talked about during your presentation at this low carb conference was things to measure, right? And during my talk on mitochondria, I mentioned a couple of things too. I think I talked about bilirubin and GGT, and I also talked about uric acid, which is something you brought up. So I use these as measures of oxidative stress, and I use it partly to inspire people to know, you may have some inflammation and metabolic stress in your body. Let's see what it looks like after we make these dietary changes, and it's a way to kind of hook them and get them to pay attention. But these markers are not perfect. I mean, I think some are pro-oxidant in certain environments and antioxidant in others. So it gets particularly uric acid. So I want to talk a little bit about what's your thoughts on measuring things like uric acid, and is it pretty standard for you to measure these types of markers for your patients who are getting
So let me step back for a second. I'm going to come to that. But,
okay.
This is not a diet. It becomes a way of life, and it should evolve over time as we correct some of the metabolic dysfunction.
Okay.
And therefore, what we eat has to change slightly in terms of proportions as we evolve through this. So we eat a certain way to correct certain diseases. For example, every newborn baby is fed formula or breast milk milk preferably.
That's right.
But you don't live, as far as I'm aware, you're not still breastfed.
Exactly.
Okay.
That's
so
correct.
The point is you've grown, you've gone through the breast period, and now you're eating real food, and you've modified your diet based on your age and based on where you are. And if this is going to be a diet for life, not just a weight loss diet that you do for 8 weeks to lose 20 pounds, it has to evolve. The first part that I use with my patients, so at entry into our practice, I do baseline blood work, and it's very robust to look at all the different interactions. Because the other key thing to understand is one number never stands in isolation.
Right.
So they're all integrated in metabolic health. As you know, every number influences another one, because the human body physiologically functions on a negative feedback pattern.
Yes.
So every reaction needs a counter reaction to modify it. And a large part of metabolic disease is this. And metabolic health is this.
Mm-hmm.
So we take these wide swings in our hormones and try to create them into almost a vibrational force because they're so fine-tuned. So what we have to do with the diet is help people to restore metabolic health and then maintain metabolic health. So my first approach is a low carbohydrate, high fat diet to induce the primary issue, which is insulin resistance. And what you want to do is to get to a point of insulin sensitivity. Once you are insulin sensitive, you are then going to use what you're eating very differently. You're going to use your protein differently. You're going to use your fat differently. And sometimes if you continue to do, especially if you migrate more toward the carnivore, a high protein, high fat diet, or an exclusive protein fat diet, that excess can supersede the peak capacity of your body to benefit from protein as a nutrient. Now you've got to deal with the excess, just like you have to deal with excess sugar and it causes insulin resistance. Now you're getting to the states of protein and fat resistance, which is your body is now having to take that excess protein and turn it into storage products. And therein lies the problem. So things like uric acid look at the nitrogen component, and it's a waste product. It's also an antioxidant. So we look at liver function, we look at hormonal function, which is sex hormones, thyroid hormones, and then your nutritional hormones, your insulins, your glucagons. We measure all of those. We look at the different sugar compartments, so the A1Cs, the blood glucoses, but we also look at insulin C-peptide. So we look at everything, and then we look at your immune response. Immune response is your white blood cells, but it's also ferritin, it's also gamma-glutamyl transferase. It is the white blood cell count. Some people do CRP. I don't find that of great value. But we look at those inflammatory markers and say, okay, what is the condition of his immune defense? Is it ramped up because you're triggering it all the time by creating all this inflammation? Or are we dumbing it down? And the value of having that first set of blood work, we can then calculate or track healthy progression. And what we found is that in our veteran carnivores, who at least the simplistic keto definition should be the healthiest people, their A1Cs are below 5.2, their insulins, their C-peptides are super low. Now the uric acids are going up. Now their fatty liver is coming back. And it's not because the ketogenic diet is bad. I don't want enemies of what we're doing to victimize us and say, well, it's a bad diet. It's not. It's how we're doing it that's the problem, like anything. Okay? If you run all the time and you get shin splints and you keep running, it's going to cause damage to you. So it's the same thing. Listen to what your body's doing. We've got to monitor that. So in that patient population, we're now getting them to eat more frequently so that they're not having this massive excessive load they're dealing with at one time. And then we cycle them. So for those folks, we'll cycle them through a high protein, low fat, and then sometimes protein and fat. Some of those folks, if they're comfortable, we even have a few vegetarian days or a few more vegetable days. And for certain of the folks, especially the athletes, we may even introduce just a little bit of carbohydrate so that they're not only living on protein. We actually want the insulin to come up a little bit. Exactly. Right, but that's for you. Now, we also have to mitigate that because there's no circumstance under which I should have a bite of your mother's sweet potato pie. But for you, that's different.
Gotcha.
Does that make sense?
Now, but some people like Joan Iflin talks about how our neurons they have memory and man, she would maybe argue to stay away from the things that trigger you. So are there variations on that theme where you can actually, once you kind of become metabolically healthy, let's just say you've done that, and should you then have permission to do the things that that got you in trouble as long as you can kind of control it? Is that individualized?
Tony, no, it's not individualized. It's addiction. So I've never met a heroin addict who can just use heroin on Tuesdays.
Right.
Okay?
I love that.
I've never met the alcoholic who can just have one sip of beer.
That's right.
They may be out there, but I would not roll that dice. If you've worked,
there you go.
You know what I tell people is this, and it's an evolution. The first statement, which is one of my favorite statements, is I didn't come this far to only come this far.
Right.
That's the first thing.
That's right.
The second thing, though, that happens over time, especially through carb abstinence, like a lot of other addictions, if you talk to someone who's 6 months out from smoking, I really want a cigarette, I can't have one. There's a sense of deprivation. You talk to someone who's 10 years out, that's disgusting. How can you smoke?
Right.
And the best defense in terms of sustainability is what I call arrogance. And when you are arrogant about the fact that I don't do that, you don't feel deprived. And then the other piece that we like people to focus on, and this is the big difference between addiction management and diets. Diets are all about what you're not allowed to eat, and they focus on the deprivation. What I like to focus on is here's what you can eat.
Yeah.
And if I'm thinking about can I have chicken, or do I feel like chicken or steak or tuna tonight for dinner, I've put a boundary around those choices that I can give myself, and I'm empowered to what I can have, rather than I'm not allowed to have this, I'm not allowed to have that, or trying to find a substitute. I'm going to have cauliflower rice.
That's right.
That's lunacy.
Right.
That perseverates the ideology. It's like drinking. It's like an alcoholic drinking O'Doul's. It's a question of time.
I know.
So we've got to understand the psychology of addiction in order to have people help themselves to let go over time.
But what's I remember when Joan Iflin spoke today, people who had questions and answers. It was like nobody knows about this stuff. So I'm thinking about you and her, and how many people even know that there's such thing as a processed food addiction at all. I just feel like it's an unknown entity, and how then can you help people if the root cause of why they do what they do is an addiction, and we're just focused on just reduce your carbs? It seems like we got a lot of education to do.
No question. And it's distorted by the manufacturers. But if you think back, I think you and I are both old enough, the 1950s and 60s, even us physicians were advocating for cigarettes. No harm here. And yes, the tobacco companies fostered that by hiding some of the negative data.
That's right.
If you step back from smoking, even in the 1950s, it's so obvious that it wasn't a good idea.
Right.
But we were conned into this. We had that cognitive dissonance that Tim Noakes loves to talk about. And we're currently still in large part in that same era, but there are a few people that are raising their hands and saying, hey, you know what, this is that. When I started, even with Low Carb USA a few years ago, it was all about obesity. Now, and it was all about calories and diet.
Right.
We've evolved already just in a short period of time to look at metabolic disease. Today we talked a lot about cardiovascular disease.
That's right.
It's not about LDL and fat, it's about sugar.
That's right.
And so it evolves very quickly. But ultimately, Tony, they still sell cigarettes. And the challenge for us is to understand that our society is not going to embrace this because the economics of consumerism are against what we're doing.
Yes.
Okay? So, we can try and fight that battle. We're not going to win it. What we can win is the battle with each individual person that we encounter.
That's right.
And it takes more and more of us physicians and us practitioners in the field to understand this, and then at least offer the option and the knowledge to the patient. Should I take a statin? I'm not going to tell you should or shouldn't. I'm going to give you the evidence that as I see it. Your cardiologist is going to give you the other evidence. But you know what? You're a consent-giving adult. Once you are fully informed, you make the decision.
That's right.
Does it make sense? It really is empowering each individual patient to help them to make better decisions about their own healthcare. Because there's only one thing I can guarantee every one of my patients 100%. You know what that is? They're going to die.
Guaranteed.
They're going to die. Guaranteed. Right. So the question is, what pathway do we choose to follow to get there?
Right. That's right.
And as you see, a lot of people choose the pathway of carbohydrates without the knowledge, like they chose the pathway of smoking without the knowledge, because it's an incredibly powerful, positive thing. Once you give them the knowledge of the negative, then it's incumbent upon them to say, I don't care. I'm going to die anyway. I'll die this way.
Right.
Or like Ivan, we've chosen not to die that way. Okay. But we are all in charge of that pathway. Now, not obviously there are higher powers involved here, but at least we can mitigate against the harm we're doing to ourselves.
Yeah. And I just feel, I don't know. I'm sure you've had this experience when you're helping people for the first time. In my career, and it's probably been about 8 years with this approach. And that's without even really fully, I think I'm a little bit of a therapist.
Every good doctor is.
Oh my God. So I think I do a little therapy in clinic, and I try to coach people through their journey. And then I'm a little bit of a mentor when people are asking, well, how do you do what you do? So I do the mentoring role under those circumstances. But it's a game changer when you are helping one person at a time. And then of course we try to reach more people when we come to conferences like Low Carb USA, and I know you travel and speak throughout the world. So I really appreciate that as
I travel
well.
and learn, not just travel and speak. I
Got
learn
you.
everywhere I go.
Really?
Oh yes. Oh
Yeah.
yeah. I mean, I learned so much today and yesterday, and
Yeah.
because everybody's having these similar thoughts and similar ideas, and they're advancing what we do collectively. That's
That's
what I
right.
love
That's
about
right.
it.
That's
So
right.
it's an evolution of a management style and management
That's
pathway.
right. That's right.
But ultimately, it's about choices, and we physicians also have to choose how we practice. Because if you're seeing someone for their blood pressure, you can do that in 5 to 10 minutes
That's
because
right.
here's your
That's
medication,
right. That's
right?
right.
But if you are helping someone to understand why they're hypertensive, and maybe if you follow this paradigm, we can get rid of your blood pressure. Because essentially, it's not essential hypertension, it's carbophilic hypertension.
That's right.
You need more time.
That's right.
It's very simple to treat something. Here's a number, here's a medication
That's
for
right.
it.
That's right.
But you're not really treating, you're
No,
modifying,
you're
you're
not.
slowing
Right.
down
That's
progression.
right. That's right.
So, what I've done in my own practice, and one of the
Mm-hmm.
reasons I'm private practice, is I've allowed myself more time per patient
Mm-hmm.
so that I can help them to help themselves as opposed to throwing medication at them. So, the industry of healthcare is as much complicit that we've become therapeutic in terms of here's a number, here's a pill, rather than diagnostic
That's
and
right.
and approach driven.
That's
You
right.
know, how many patients do you not see that are on thyroid medication? 82% of my women that walk into my office are on thyroid medication. And why are they on thyroid medication? Because they're hypothyroid.
Mm-hmm.
Hypothyroid is not a diagnosis, it's an observation. And
Mm-hmm.
they're destined to be treated for the rest of their lives for an
Forever.
observation. Hashimoto's can be reversed. Maybe it's iodine deficiency. Maybe they're carnivores and T3, free T3 of 2.3 is normal for that
That's
person.
right. That's right.
So we've got to be able to step back and assign a diagnosis
That's right.
to the number. And perhaps you can treat the root cause and get rid of the disease.
But the docs have to, and if you think about my discussion about mitochondria, it was really an opportunity for us to say, don't make any assumptions. I think one of the examples I used was, when you're anemic and you're getting your iron and you're being treated, but you're not getting better, and how, well, there's other things that maybe led to that. Maybe you're copper deficient, and I think I used that as an example. But we're not really taught to even know that hypothyroidism is not the diagnosis. Like, we're not taught to think that way. When I started my whole journey, inspired by my wife, it was about her being diagnosed with an adult onset diabetes. And when I started to think about it, I said, well, is it really a high blood sugar? Is that the real disease? And then I learned, well, it's not, it's something deeper. And I learned about insulin resistance. That wasn't even in my vernacular. I wasn't even thinking that way. So then I was like, oh man, so me controlling their blood sugar is controlling their symptoms. It's not getting to the root cause. And then once you start thinking about the root cause, now you can help people. And it's okay to take a medication, hopefully short term. It'll definitely, keep
You
the,
still have to treat the
yeah, you have to
disease
treat the, right. You still
while
have to
you're
do
treating
it.
the cause.
Right. You got to
No
do
question.
both. And
Yeah.
I think for everybody, and I know you guys didn't get a chance to listen to my conference if you didn't sign up for Low Carbs Conference, and hopefully they have access afterwards. But the point of it is, you have to sometimes be your own detective, because we're kind of like, what did Dr. Brett show? We're like the blue.
The blue
The
penguins.
blue
Yes,
penguins, like,
yes,
so you
yes,
have
yes.
he had a nice image of penguins, and they were all kind of gray looking. There was one blue one, and so sometimes we feel like we're the blue penguins because the rest of the world hasn't caught up. They're still following guidelines, and we're kind of looking through a different lens. But sometimes it requires you to be your own advocate, and you can go to the Society of Metabolic Health Practitioners and find somebody in your area. But what if you don't find somebody in your area? And even with that, you don't want to depend on that person. I've had so many patients come to me with a journal article, and it'll speak to what their concerns are. And then they'll use me to kind of coach them through: is this a valid study? Can we do more deep diving? And I think you never should give up. There's no such thing as no cause for your condition, or we don't know what it is. There's always a reason. So I just want to encourage everybody listening to take advantage of that. Now, having said that, I know we're getting close to the hour here. I do want to take a moment to ask you, when people struggle, you're a surgeon. First of all, how do you make a living doing all this lifestyle stuff? And you're a surgeon, so you may want to answer that question.
Yes.
But the bigger question is, when do you know this person is a surgical person? That person's going to
Right.
have
And I think, first of all, consults and things like that are sawdust. Surgery's 2x4s, but a
Mhm.
lot of sawdust still equals a 2x4. So
Right.
that it works out okay there. But I think one of the things that we're remiss in as physicians, and because our time is precious and all of those things, we want the patients to do what we want them to do.
Mhm.
And we tend to expect the patients to adopt our approach to stuff. You
Right.
must take your
Right.
statin.
Right.
The approach that I use is to see what the patient as an individual is capable of.
Mhm.
What do I think they're capable of along this journey? So there's some people that can get rid of carbohydrates in a day. There's some people that may take a month to get rid of carbohydrates.
Okay.
I've got to be empathetic to their capacity to change. And if I know that I see them putting the effort in,
Mhm.
but they're struggling, I'm going to make that suggestion for, hey, you know what? Let's add a tool in here. Maybe it's
That's
a
right.
balloon in the stomach,
That's right.
which is temporary. Maybe it's a sleeve gastrectomy. It's not just surgery. There are various options.
That's right.
Okay. At the same time, I get people coming and say, "You're a surgeon. I want surgery." I have to talk those patients backwards off the ledge. To say,
Gotcha.
look, I can do surgery on you tomorrow. You put a pile of money on the table, I can operate on you.
That's right.
But it's going to fail because you're not addressing why you gained the weight in the
Mhm.
first place.
Gotcha.
Let's partner on this. My job is the surgery, you show up. Your job is to address the cause.
That's right.
And together, that advances you. So we have to pump the brakes on those folks and slow them down.
Okay.
The others that I'm going to make the suggestion, at least consider it. And if they say, no way,
That's right.
that's fine. If they say, yes, it is an option.
Gotcha. And that's good to know. And I guess it also is, you're kind of implying, I think that I always tell patients you still got to do the dietary change. You still, and obviously in what we've discussed today is that they need to, get to their emotions and understand why they ate the way they ate in the first. Why am I carb addicted? So it sounds like they need to. That's going to have to be addressed regardless. I even had a previous guest on the podcast, and she basically, I think she had done. Weight Watchers, and then but then she had surgery. And when she had surgery, she still ended up with a stall because she went back to those types of things that led to it. So I think that's really insightful. So I really appreciate that.
Well, all our patients are pretty much experts at failing weight loss programs.
Right.
And if they approach surgery like another weight loss program, they shouldn't expect a different result long term. Early on, they lose a lot more weight. But long term, the results are no different unless they address root cause. And that's really what it's about.
I think that's great. So I just want to get us to our final thoughts, and I always, ask my patients about my acronym, NEST and ROPE, and rather it's nutrition, exercise, less stress, more sleep. I'll be doing Dr. Ben Bokikio's, and I'll be doing his bands. I have my bands in my suitcase, and I'll be doing that, tonight. We think about, avoiding trauma. We think about positive thinking. Then when we get to the rope, we think about our relationships. In fact, for the diet doctor, my next column, I'm going to give my thoughts on relationships and how important that is. Avoiding organisms, avoiding pollutants, rather than the environment or what we eat, and of course, protecting our emotions. So, this podcast episode, we talked a little bit about the nutrition, but we definitely went from that N all the way to that rope, that E, and we talked about emotions with the work that you're doing. So, and our life experience is another reflection of that E. So, when it comes to your life, when you think about that NEST and ROPE acronym, and I know you're busy, I know you've been traveling, what are you doing to protect your nest? Which parts of that are you going to focus on?
Well, I think the first thing is what I call the oxygen mask theory. When you're flying on an airplane and the air pressure goes down, you've got two young kids sitting next to you. The instant thinking is help the kids.
Of course.
But if you're dead, you can't help them effectively.
You can't do
so
it.
So self-care first, you put your own oxygen mask on first, and then you're more equipped to help those around you. And people like you and I who are in the clinical trenches, who get a lot of reward from the people we help, have to understand that we are our own first patients.
Right.
The first patient of the day that I see is the guy I see in the mirror. And I have to work with him. I have to have an appointment with him as the first person on my schedule each day.
Nice.
And I got to revisit with him many times through the day. So that's the first thing, is self-care comes first because it's not selfish. It is you're better equipped to handle other people's needs.
Mm.
The second thing is, as we go through this, is take risks. And what I mean by take the risk of being immediately vulnerable.
Mm.
So you'll say, you know what, I should go for a walk or a run today. But for these various reasons, take the risk of putting the shoes on and starting the run. And you know what, if you walk out the door and you're 5 yards down the road and you don't feel it, come
Right.
back.
Right.
Because you took the risk. And the best relationships start or function through the medium of vulnerability.
Right.
And vulnerability and relationships are not just with other people, they're with yourself as well.
I love it.
Does that make sense?
I love it. Yes.
So take those risks.
Yes.
Take the risk of reading a book instead of watching Netflix. Take the risk of acting on an idea, even if it doesn't work out. Because if you don't take the risk, you haven't started.
That's right. I love it.
So I don't mean risk by risk behavior.
Yeah, just
take the risk
calculated,
of doing.
Calculated risk.
Because all too often, we consider the outcome first and don't take the risk if the outcome's not going to happen.
That's right. It'll paralyze you. And you're right. Self-care is not selfish, 100%. And, I was a little nervous getting on the stage at Low Carb USA in the midst of my peers. That's a little more, I get in front of people all the time in my health system, 200-300 people, their patients, etc. But man, but you gotta take the risk.
But if you take that risk and you're vulnerable, say, hey, listen, I'm a little risky here. The audience will give you the buoyancy you need to flow through the talk.
Right, get you through it. So, and I 100% agree. So it's awesome. So thank you for sharing how you're going to protect your nest, and I hope that inspires others. So we'll wrap up with that. And as we wrap up, any thoughts on how people can find your work? I love your YouTube channel. So share some of the work that's available for people to continuously learn.
Right. I think the biggest footprint that I have try to get for the audience worldwide is our YouTube channel. There's a lot of content there. It's free. There's a number of videos. That's a great place to educate yourself on different topics. I also put motivational stuff out on Instagram every day. Cool. My YouTube site and my Instagram is Carb Addiction Doc. And then also we've got a little 1-year-old who's growing up in a kind of omnicarnivore, mostly carnivore world. And for young moms, for people trying to do the best for their kids, particularly brain empowerment, she's Carb Addiction Mom, and she's a great person to follow.
I haven't found that yet, so I'll check that
Carb
out.
Addiction Mom is her name, and she puts out more what we eat each day, how we live our lives. I try to not be personal on my sites. I try to be more informational and scientific on our sites, but that combination works very well. And if you would like consultations or to corroborate or verify some of the findings as one-off or blood work or whatever it is, I am in clinical practice, and the way we work it, we have a single cell phone, which is, we call it our bat phone, 561-517-0642. You can WhatsApp that, phone it, or text to it, and we'll get back to you and set up a visit.
All right. Well, again, excited. I was so happy to meet you, man. So I'm just happy we had a chance to do a face-to-face. You took a little time to meet my audience, and I really appreciate that. So thank you again.
Thank you very much. And thank you for what you're doing. It really is, we're expanding audiences all over the place and in different worlds.
That's
and
right.
This will coalesce over time.
Yeah.
It's absolutely wonderful what you're doing.
It's a grassroots efforts, guys. And even for you guys who are listening, and particularly if you've already taken your journey to improve your metabolic health with carb restriction, please share what you're doing. You don't have to be preachy about it. A lot of times people will come to you and ask you what you're doing, but make sure they understand that the resources that are out there are really easy to get to. My YouTube channel, Dr. Cyrus's information he just shared, make sure you get that stuff out. So I'm just
excited. Your story. That's what it's about. Tell your story.
That's it. And people, that resonates.
It resonates.
That's right. So today we talked a little bit about how addressing carb addiction is a complex journey. It actually is pretty simple if you just follow, you have the right people leading you. But we have to think about many factors, and one of them is we may have to get some cognitive behavioral therapy to overcome our addiction. So I appreciate the insights that we received today, and I just encourage you guys to continue checking out the work that the doc is doing. So the goal is to protect our nest, but it's much better and easier if we understand why. Today we talked about the whys, why we get sick. We got to peel the onion and keep peeling it until we get to where we're trying to go. So I hope you're not disappointed with the wonderful things that you'll need to do. I think that if you just pause for a moment, we talked about wait, why am I talking? Wait, pause, think about what you need to do to be successful, and I think you'll get there. So I really appreciate everybody checking us out today. I want you to continue to take care of your families, yourself. So continue to be safe, be well, and continue to protect your nest. Take care.